Our next speaker, Tyron Pini. Tyron hails from the United Kingdom, where he began his career in the NGO disability sector after training as a community social worker. Since then, he has also gained qualifications in working with people with autism, management and health. Moving to New Zealand in 2002 with his family, he worked for Graceland's group of services. In 2007, Tyron started with Workwise Employment Limited, a specialist service focused on supporting people to return to work as regional manager for Midland North. With a strong interest in the business and employment, this was an ideal opportunity to work across a range of sectors with a clear purpose. On top of the day-to-day running of Workwise Midland North, Tyron is involved in a variety of sector activities. He is a member of the Huntly Community Link Executive Group, Waikato Mental Health Employment Group, ACC Rehab Providers Liaison Group, and a former board member and chair of the Association of Supported Employment New Zealand. Through connections created through the Waikato Chamber of Commerce, Tyron is also leading the His Biz project aimed at supporting wellbeing for men in business. Ladies and gentlemen, let's welcome Tyron Pini.
Lots of buttons to press. I think there's probably half the former or current Board of Ascends here as well, so it's a very selective audience, and I'm not quite sure how far our message will go, and I suppose that's always the challenge when we come to present about disability or mental health. It's people already in the sector that are actually in the audience, and those that need to listen seem to be absent. So I'll run through my presentation. I'm trying to speak into. Is that better? I'll lean forward. Or is that better? There we are. For us who are slightly taller, you have to lean quite far forward. So really, I mean, our key message, and it came up earlier about the interaction between the welfare and health sector, is that for us, work brings health benefits, and employment is a health intervention for a number of people with mental illness, and you can't really detach the two. It's not an either-or scenario, it's an and also. Because people are always on a continuum and need at different times. But work brings improved self-esteem, better symptom control, integration into the community, shortened periods of unwellness, longer periods of wellness, and generally improved physical health and living conditions because you have an increased income. Again, not rocket science for most of us in the room. I suppose before we talk a little bit about the model that Workwise use and a number of supported employment agencies use, there's always the traditional rehab and approaches that have been taken to support people with impairments or disabilities to return to work, and they've usually been gradual stepwise processes after treatment or care is completed, so you have to be well before you can start contemplating getting a job, not that the job may help in your wellness and recovery. There usually involves a lot of pre-vocational training, and in the UK I'm quite conscious that pre-vocational training used to be a cycle. You'd finish one course and then go on another course and another course and another course and never quite work. Work readiness assessments for your eligibility, so you had to be ready to work before you're allowed to look for work, and usually at this point I ask people how ready they were for their first job and whether anyone assessed them when they left school to say, are you ready to work? Because most of us aren't always ready for any transition in our employment. We're always nervous or anxious. Individual and illness characteristics are used to assess work readiness, not again that the individual may well be ready and a label attached to them is the barrier that's put there. One of the more contentious issues, I suppose, is that voluntary work experience, sheltered employment and transitional employment are often used. And I put that there because quite often all of those things take as much energy as getting a proper job in the open labour market for full pay. So you're kind of doing the things twice when you can just go straight to the paid employment. Because of voluntary work, if you're using that to get to paid employment, you still are working. But just without any remuneration. Again, there's been a lot of group-based approaches, so not individualised. And again, client characteristics, not service characteristics, are often used to explain failures. So the client is the problem when a job falls over or a service doesn't work, not that the service may not be delivering in the best way for an individual. So this is a quote from Drake in 2008, who's, I suppose, one of the founders around the supported employment process and the model for working with a lot of people with mental health. And I suppose there is a lot of evidence around working with people with a range of impairments and employment, and people have been doing it for a long time. So for Drake, in the 30 years when he's been following patients and dozens of research studies around the world, it's clear that nothing about medication or psychotherapy or rehabilitation programs or case management programs or any other thing that those studies have done have helped people more than supported employment does. So from a very fundamental base, supporting people into work is one of the most effective treatments for a range of impairments, but especially for people with mental illness. Now, at Workwise, we use a model called individual placement support, which is very similar to the principles of supported employment. There are a few technical difficulties, and I know some people may well have some questions around that, but it's based on 7 evidence-based principles. Mainly that eligibility is based on individual choice, so there's a zero inclusion, and this very much goes back to one of the points that Leo made, is that the individual wants to work, and it's their belief that they can work and that we're there to support and ensure that motivation occurs. So it's not about you can't work, but it is very much focused on the ability to work. That supported employment is integral with clinical treatment, and I suppose this is where the IPS model varies from some of the traditional supported employment models, but very much is in line with the Perkins review that was mentioned from the speaker from the UK this morning. And I suppose one of the critical things about this part is that there's good integration between the supports for that individual, whether it be clinical, to support the clinical service understand that employment can make a difference, whether it be welfare benefits teams and how you attach and are present in, for us it's within community links, so we've got supported employment consultants within those community link centres, and I suppose some of the evolving conversations now around within family health and primary health and GP centres to ensure that employment is a conversation when someone is signed off. With any medical intervention there are side effects, and as we've heard, if you're signed off onto a sickness benefit, the side effect is that you're likely to stay there and transition into another benefit type. So if we could be in those clinical or medical environments and help clinicians realise that employment is a question that needs to be asked, and around how people can sustain and maintain current employment if they're already in work, then that's about that front end before it gets too late.